Francis Creighton. I'm one of the neurotologists and skull-based surgeons at Johns Hopkins, so thank you for having me down. We're going to talk a little bit today about hearing loss, workup of hearing loss, and a little bit more specifically about hearing aids and cochlear implants. I think it's one of the things that no matter what field of medicine you work in, you will meet patients who have hearing loss. It's pretty much the single most common reason people go to the doctor over the age of 75 to see an ENT. So let me make sure I get this working right. Okay. I have no financial disclosures. And here are just the list of the objectives. We'll try to talk a little bit about hearing aids and also some of the newer devices that have just come out that are over the market that a lot of patients are pretty excited about. I just put this quote up, loneliness does not come from having no one about you, but from being able to communicate the things that seem important to you. I just put this up to really try to get the point home that hearing loss sucks. It is really hard on patients, and there is a lot of really good literature that's coming out right now from actually one of my colleagues, Frank Lynn, that not treating patients who have hearing loss, particularly the elderly, their rates of dementia go up much, much higher than those who we actually treat with hearing aids or cochlear implants. So it's something that I think can often be passed off in a quick visit or quick clinic visit, that it's not a big deal, but it really can be very socially isolating for people. So just a little bit about the ear anatomy. This is the external ear. So the external ear is made up of two parts. The pinna is part that you see out, and the external ear is the actual canal that goes down to the tympanic membrane. The middle ear, which is where I spend a lot of my time surgically, is made up of the tympanic membrane, which is the eardrum that everybody sees when they look in through an otoscope. And then actually behind that, there are three bones of hearing, which most people learn about in high school. They call it the hammer, the anvil, and the stirrup. More medical terms are the malleus, the incus, and the stapes. These three bones function two purposes. One is they actually help to amplify sound. The other is that they actually help to impedance match sound as it's coming from the outside into the inner ear. So if we did not have these, most of the sound that got to the eardrum would actually be reflected off and not actually be absorbed and used in hearing. So they're very critical for hearing. And I put this slide up just to give you an idea of how small they are. So all three of the bones of hearing will actually fit inside of a dime. So that's one of the reasons it takes so dang long to actually learn how to operate on these things, is they're so small. But we actually have really got some great advances in that recently, and we can actually do a lot of work to make people better who have issues with these with any of these bones, but just to kind of give you a sense of the scale and why sometimes we freak out about it as surgeons. The inner ear is made up of two parts, the cochlea and the labyrinth. The labyrinth is your balance system, which I'll not talk a whole lot about today, and the cochlea is where you actually hear. The cochlea itself, it's kind of a snail-shaped organ. It has 2.5 turns. And inside that, it actually has three different chambers, the scala tympani, the scala media, and the scala vestibuli. So if you look, see if I can make this work. So this is your scala vestibuli. This is where sound comes in from that last bone, the stapes. It functions like a piston. It moves up and down, and it actually allows fluid inside this to be circulated throughout the cochlea. It goes through here, and then it hits the very end of the cochlea and goes back through here. And it's actually that traveling wave of fluid that lets you hear and actually sends an electrical signal to your brain. I could get very geeked out and talk to you for hours about how that works. It's a really fascinating process. So this gives you a little bit more of a schematic. So the stapes moves up and down right here in relation to the eardrum moving up and down. Fluid goes through the scala vestibuli, comes up to the helictrema, which is kind of the end of the cochlea, and then comes back down and hits a thing called the round window, which is basically the release valve for pressure in the inner ear. And it's this area in between that is actually activated and is where the cochlear nerve actually comes in and sits. So just a couple other structures that are important around this area, and one of the reasons that operating in this area, we need microscopes and a bunch of other specialized equipment. The brain is pretty much brain pretty much is at the very top of the ear. So the nose is up here, back of the head is here, top of the head is here, and feet are down here. So this is the facial nerve, that yellow thing right there. This is actually the view we get for a cochlear implant surgery. You can see the ear canal would be here. the brain is here, and the sigmoid sinus, which helps to drain blood flow from the brain, is here. So these are kind of the structures that are around the cochlea and that we have to deal with often surgically. How hearing works, pretty much sound comes in through the ear canal, it vibrates the tympanic membrane, then it makes the malleus, the incus, and the stapes all move, and then it goes to the cochlea. And from there, it actually fires along the auditory nerve, and there's a whole lot of science that I could talk to you about the actual how the brain interprets sound. We do not understand that quite as well as we understand this system, but we're working on it. Basically, the beginning part is here, and then this last bone is the most important bone. So there's a disease called otosclerosis that you'll probably see a patient or two in your lifetime who has, and that's actually that third bone of hearing actually gets stuck. And when that third bone of hearing can't move, you cannot actually process and send sound along as well as you should. This is just another schematic of the cochlea, but one point to get home, if you Google how hearing works, there's a wonderful YouTube video that's about 6 minutes long that if you read that and watch that, you will know more about hearing than most of my residents. But the best thing about the way that the ear is shaped, and the reason that we can do cochlear implants, is that the cochlea itself is actually what we call tonotopically mapped. So if this is the very, what we call the basal turn, so the very beginning of the cochlea, and this is the very end of the cochlea, at each different points along here, the nerve fibers that are set up actually preferentially respond to different frequencies of sound. So different frequencies of the stapes vibrating cause different frequencies of sound to move through the cochlea. So very high frequency sounds start to vibrate here. Very low frequency sounds will start to vibrate here. And it's this tonotopic mapping that actually allows us to do cochlear implants. It's the reason that cochlear implants are so successful, but all of our attempts at trying to make a bionic eye are not, because the eye itself is not tonotopically mapped. So I know that if I put an electrode right here, I know that electrode should correspond to high frequency sound. And if I put an electrode up here, I know it should correspond to low frequency sound. So a lot of what we do to actually make people hear well with cochlear implants is fine-tuning these electrodes to make sure that they're playing the right sound at the right location. So when we think about hearing loss, we break it down into two ways. One is conductive hearing loss, and one is sensorineural hearing loss. So conductive hearing loss means something's either wrong with the ear canal, the eardrum, or the bones of hearing. And sensorineural hearing loss means that there's something wrong with the actual cochlea or the auditory nerve. So conductive hearing loss is a problem of sound not being able to get into the ear and into the cochlea. So you can have that problem because you have a whole lot of earwax. I do lots of skull base and brain surgery, and it sometimes makes me sad. My happiest patients are the patients who have wax in their ears and I take it out. But it's true, it really is. I mean, these patients, they come in, they can't hear because their ears are entirely plugged with wax. You take it out and you actually increase their hearing about 30 to 40 decibels from that. If you have a hole in the tympanic membrane or otosclerosis or cholesteatoma, those can all cause a conductive hearing loss. You can actually demonstrate on yourself a conductive hearing loss. If you just stick your finger in your ear, you actually give yourself about a 30 to 40 decibel conductive hearing loss. So that would be about the range of sensorineural hearing loss that we would start thinking about a hearing aid. Sensorineural hearing loss, sound is getting into the cochlea just fine, but it's not getting from the cochlea to the brain correctly. Conductive hearing loss, pretty much all forms of conductive hearing loss, I have a surgery that can fix that. It can be a lot of different kinds, but we can almost always fix the underlying problem of conductive hearing loss or just bypass the system altogether with a bone-anchored hearing aid. Sensorineural hearing loss, though, is not something we can fix until it gets bad enough to need a cochlear implant. So our stopgaps for that are hearing aids, which we'll talk about. But in general, I think of these in kind of three different ways. One is congenital, so children who are born deaf. Acquired deafness, so if you have meningitis, if you get gentamicin or other medications, you can acquire deafness. Or as we all get a little bit older, with our rapidly aging population, this is actually becoming a bit of a national healthcare crisis with the amount of people who are losing hearing loss over their age of 70. Pretty much if you're over the age of 75, I can pretty much guarantee you at least have around a 15 to 20 decibel hearing loss on average. So In terms of working up hearing loss, this is one of the slides that I hope kind of people take the most home from. One of the first questions you should ask somebody if they come in for hearing loss is, when did it happen and how fast did it come on? If someone says, oh, it's gradually over the last few years, okay, they should get sent for an audiogram and worked up. But if someone comes in to your office, or you have a friend or a family member and they say, hey, I woke up one day and all of a sudden I couldn't hear. That is one of the few otologic emergencies that we have. One of the great things about my field is I do lots of surgery, but not a lot of emergent surgery. Anyone who's a student, I highly recommend looking into that for your life choice. But this is one of the few things that is an otologic emergency. So if you have a patient who comes in and says, hey, look, I suddenly lost my hearing, you need to work that up and you need to find out if it's a nerve hearing loss or a conductive hearing loss, because if it's a nerve hearing loss, we can treat them, but if we don't treat them within about 2 weeks, their outcomes are significantly less. So other questions you should ask, is it one side, both sides? Is there any pain or drainage associated with it? And oftentimes you should also ask if they're having any dizzy or balance symptoms. The labyrinth, which is your balance center, and the cochlea are all part of the same bony structure, so oftentimes an issue with one will affect the other. Just to harp a little bit more on sudden onset hearing loss. So what we call this is idiopathic sudden sensorineural hearing loss. Every now and then there's a reason for someone to have a sudden hearing loss. They can have a clear autoimmune issue or a clear viral issue. Most of the time though, people who come to see me with sudden sensorineural hearing loss, there's no reason we know of. We have spent lots of NIH dollars trying to figure out why this happens. We have theories, but none that I think is good enough to tell you yet. It used to be thought that this was all kind of the equivalent of Bell's palsy in the ear. Now we probably think that's not true, but what matters is it's rare, only about 2 to 20 people in 100,000, but treatment needs to be started in 10 to 14 days. So actually at the very end I have our clinic offices phone number. We actually leave slots available for these people. So if you call and someone says, hey, I have a sudden drop in hearing, we will find a way to get them in and get them seen soon. Because we can treat them with steroids. We don't fully understand why steroids help, but we know they do. And we can give them either oral steroids or someone who has diabetes or another reason that they can't take oral steroids. We can actually do steroid injections through the eardrum. So one of the things that happens is a lot of times patients will see their primary care doctor, they'll go to an urgent care, and they'll be like, okay, you have hearing loss, it's probably wax, or I see some wax in the ear, I think that's what it is. Don't worry about it, see someone as soon as you can. You can actually tell very quickly in the office without an audiogram whether or not this is a conductive or a sensorineural hearing loss. So you might remember this from school. Most people don't. The Weber or the Rene test. I have made it very easy on your right-hand side. If you take a 512 tuning forks, you don't have to remember anything at all about Weber and Rene. But if you put the tuning fork on the person's ear, on the person's teeth, and they say, hey, I can't hear my left ear. If the tuning fork goes to the left ear, they say they hear the tuning fork louder in the side that they have hearing loss on, it's a conductive hearing loss. It's okay. They need to come see us, but they don't need to come see us urgently. If you put it on their mouth or on their teeth and they say, hey, look, I hear it louder in the side that I didn't lose hearing in, most likely that's a sensorineural hearing loss. And so that's something that we would say, hey, give us a call, we will get them in 2 weeks. There's actually some good literature as well to looking at if it actually doesn't lateralize. If someone says, hey, I have hearing loss, and then I can't really tell you which side it's in, they probably need to be seen as well too. About 20% of patients who have a sudden sensorineural hearing loss won't actually lateralize to a side. So if you forget anything else I say today, this is a thing that could really help a patient of yours. So off of my post about that. Workup of hearing loss. The first thing we will do outside of a physical exam is to get an audiogram. So audiograms are, they take about anywhere from 15 to 30 minutes to do depending on the type. We're testing 2 things, or really 3 things. One is how loud and how soft of a sound can you hear? And then also how loud and soft of a sound can you hear that is conducted through your ear, so in the normal way, so just putting a headphone in your ear, or how loud and soft can you hear if we actually vibrate your skull? Vibrating your skull actually bypasses the middle ear apparatus, so what this allows us to do is we can actually test how well is the conductive component of hearing working, and then how well is the nerve component of hearing working as well too. So I'll show you a couple examples of that, but if you send someone to an audiologist and they send you back a test that does not test air and bone hearing, that's a crummy audiogram and you should send them to somebody else. A good audiogram should test both. A lot of times people will just test one because it's quicker, but you're going to miss a lot of pathology that way. So if you want to take a quick look at this, from left to right, we're looking at low frequency to high frequency noise and very quiet to very loud. So we think of, it's a little bit counterintuitive, but basically anything that's higher is better. Anything that's lower is worse. So we think of anything between 0 and 20 decibels hearing level is normal hearing. So this is a normal hearing audiogram. If I go to this is evidence of a conductive hearing loss. And the reason for that is these are a little bit hard to see, but basically there's some small symbols in here, that look like this. So this is where you're actually hearing on the right side. So red is right, blue is left. It helps us remember. This is how well this person is hearing sound conducted through their ear canal on the right side. If we were to actually vibrate, and you can see this is this little backwards mark right here, this is actually a way to tell you that if I vibrate on their skull, they actually can hear just as well as the other side, but it's a conductive problem. They're not getting sound in correctly. So this is an example of conductive hearing loss. And this would be an example of sensorineural hearing loss, or nerve hearing loss. So again, that same little check mark is down here instead of up here. So that's kind of how on an audiogram we differentiate it. The final thing we test is not just how loud or how soft of a sound you can hear, but how well can you understand sound. And that's really important, particularly when we start talking about hearing aids and cochlear implants. People who have lost the ability to hear very soft sound but are still getting in crystal clear sound are great hearing aid candidates. Because if you take clear sound that's just really low and you amplify it, it's going to be good, understandable noise. But if you have someone who, even if you crank the volume up all the way, they have a hard time understanding sound, a hearing aid's not going to help them as much. Because if you're taking garbled sound and you make louder garbled sound, it's just louder garbled sound. And so that's oftentimes when cochlear implants can be appropriate. So when I talked a little bit about treatment of conductive hearing loss, again, that is something that should see an ENT, someone who does ear surgery, because oftentimes that can be treated surgically. This is just some intraoperative pictures of a Mastoidectomy, which is just fixing that third bone of hearing. But when we talk about sensorineural hearing loss, really the first line treatments are hearing aids. So hearing aids, again, they're great for people who retain the ability to understand sound, but have just lost the ability to hear soft sounds. And this is the most common type of hearing loss that people have. If we say presbycusis, which is kind of the medical term for age-related hearing loss, that is what people have. They lose the ability to hear soft, high-frequency noises. So getting them a hearing aid can do wonders for them. But it's not great if you've lost the ability to actually understand sound. So this is an audiogram of someone who has kind of what we think of as classic presbycusis. So in the low frequencies, they hear pretty well. And as you get out to the higher frequencies, they don't hear quite as well. And so a hearing aid, and the hearing aids, while they're stupidly expensive, actually have pretty good technology behind them, they can actually amplify sound just in the high frequencies. Because this person doesn't need amplification in the low frequencies, but they can kind of tune the hearing aid to what their hearing loss is. This is just a little bit of background on hearing aids. If you have patients who are interested in that or want some basic information, actually the AARP is a great resource for that, and one that does not seem to have much of a financial bias towards them. One of the issues with hearing aids is that they are extremely expensive, and people can make a lot of money off selling them, so there is oftentimes a little bit of a conflict of interest. So I try to recommend sites that don't really have skin in the game, so to speak. And also I would recommend sending patients to an audiologist group that doesn't get paid per the hearing aid they sell. Just from, that's my own personal thing. Some people might disagree with that. But this is also just kind of a breakdown of the different types of hearing aids. One of the first things most patients say when I say, you probably need hearing aids, is they're like, oh, I don't want hearing aids. They're going to look terrible. I'm going to be an old man, old woman. There are lots of different types of hearing aids, many that are so small that you would never know someone has it in. And for people who have just a little bit of hearing loss, smaller hearing aids actually do great. They do really well. For people who have significant hearing loss, you're going to need something that's a little bit bigger. But in general, we have, BTE, which is behind the ear hearing aid. a mini BTE, which is behind the ear, but the processor that goes in the ear canal is invisible. You can see it, but it's usually a clear plastic tube. There are ones that are fully in the ear, and the ones that are fully in the ear canal. And these are the ones that you truly can't see from the outside, but they also have the least ability to amplify sound. So people who have a little bit of hearing loss, this works great for. People who have a lot of hearing loss, not always the best choice. One other thing to discuss, and this is kind of on the, I guess you would call it the cutting edge of hearing aid technology, but one of the issues for people who have or who need hearing aids is that they're very expensive and they are treated like contact lenses. They're generally not covered by insurance. I am very hopeful that's going to change in the near future. We've been lobbying very hard in Congress to get that to happen. It one day will, I think, but we're not there yet. So one of the problems is that they're very expensive. And so people have been trying to find alternatives around this, and you can't technically market something as a hearing aid that's not approved by the FDA and gone through all the 510K processes, which means it's expensive. Recently, in the last several years, they have approved things that are called personal sound amplifiers. So a personal sound amplifier this is the FDA guideline for it, so I will not speak of anything that is off-label, but it is not intended to make up for impaired hearing. Instead, it is intended for non-hearing impaired consumers to amplify sounds in the environment for a number of reasons. Do with that what you will. They are good options for people who have just a mild amount of hearing loss. I don't think they are things that people should get without ever actually being evaluated for their hearing loss, and I think that's one of the things that there's a large concern for is people will get these and not actually get evaluated and will miss actual significant underlying problems. But they can be very good options for patients. And if you have any interest in this, Carrie Neiman, who's one of my colleagues, she actually runs a nonprofit that's running a large randomized controlled trials sponsored by the NIH right now, looking at how well these do in lower resource settings. So, and I think the results are probably going to be very good. So it's something that's newer, that's out there. With it being newer, there are lots of people who are trying to get to market with this. So if you Google on Amazon PSAP, you're going to find like 8,000 different options, not all of which are reputable. Another good, the AARP is actually a pretty good resource, and the Hearing Health Foundation is also a pretty good resource that has some breakdowns of ones that are made by companies that are kind of in this field and are not just making something that's going to break in a week. They're still not cheap. They're still a couple $100s, but they're not the thousands of dollars that hearing aids are. And for patients who have significant hearing loss, oftentimes these aren't going to be enough. But for the right patient, these can be a good option. But what do you do when a hearing aid is not enough? Lots of patients kind of get hearing aids and they feel like, yeah, it helped for a while, and then over 5 to 10 years, it's just not really doing it. I crank the volume up as loud as it goes. I get the biggest, boomer on the side of my head, and it's still just not letting me hear. I still can't go to restaurants. I still can't talk to people on the phone. What's the next option? And that's really when kind of cochlear implants become something that's considered. So these are just the technical indications for cochlear implants, and I put this slide up just to kind of give you an idea that cochlear implants have been around for a really long time. They were first FDA approved in 1985, but like your personal cellular phone, they have undergone dramatic improvement since then. I think in the 80s and early 90s, and even kind of the late 90s, early 2000s, there was a bit of a hesitancy, particularly with children, to go forward with cochlear implants, with the thought being that it was not going to be something that was worth it for them. And I think at that point in time, there probably were some pretty reasonable arguments for that. Now, though, if I get a child early enough and I implant them before a year and a half or 2 years, and they perform well, that child's going to go to normal school. They're going to be able to talk on the phone. One of the things that parents get frustrated with is now they actually link to your headphone or your iPhone. So the kid can literally decide to tune out their parent, literally. They can just put music on and be like, I can't hear you. So they do very well. And I state this because we do a terrible job of catching the patients who would fit this, particularly in the adult population, but also in the pediatric population. So the CDC estimates that of the children who are born deaf who would benefit from a cochlear implant, only about 25% of them actually ever get implanted. And there's a whole list of reasons for why that is. And we're doing better, but I think a lot of it is just lack of awareness and lack of awareness of the benefit of them. But if, for the right candidate, a cochlear implant is a life-changing procedure. In terms of where we are now, I won't get into all the nitty-gritty because I could bore you for hours with it, but there are lots of different types of cochlear implants now. There's 3 main companies who make them. There are some now that are designed just for high-frequency hearing loss, which are called hybrids. Sorry about that. And we even have gotten to the point now where the FDA just approved this summer to actually allow cochlear implantation for people who just have hearing loss in a single ear, so what we call single-sided hearing or single-sided deafness. Those people have a very hard time localizing sound, and so we've just recently gotten approval to do that. But in general, this is kind of the criteria that you need to be considered a cochlear implant right now off Medicare. So if you understand less than 40% of the words that are said to you at a sufficiently high volume, and your other ear can only understand less than 60% of the words, you are a candidate for a cochlear implant. And that is one of the first things that we test. And then there are also some other things that we do that are a little bit more advanced to test people that are actually how well they hear in noise, because that can oftentimes be the biggest issue. Is people are okay one-on-one, but the moment you put them out in kind of the environment or at a restaurant, their hearing just kind of dies off. So another thing about cochlear implants, and I hate to harp on this, but they are also stupidly expensive. They are handmade, which seems silly in 2020, but they are literally handmade. I've gone out to a couple of the company's factories, and they have people who literally spend all day looking underneath a microscope, placing these electrodes by hand. So they are very expensive, anywhere from $20,000 to $25,000 a piece. And implanting a cochlear implant, while we are now to the point where oftentimes we can actually preserve what residual hearing you have, it definitely puts you at risk to lose what residual hearing you have. So we really only try to implant people who we think are great candidates, but that's one of the reasons to kind of send them up to either us or the group at Maryland to get evaluated and kind of let us figure that out. But we try not to be too gung-ho with it. We try to really reserve it for people who are going to get great benefit. Just a little bit, one other kind of press box stump that I'll get on is the importance and the timing of hearing loss. People do much better if they have spent less time deaf with cochlear implants, particularly children. So if I have a child who is a year or a year and a half and I implant them, they are in all likelihood going to get a great outcome. If I take that same child who is born deaf and I get them at 4 or 5 years of age, maybe they're going to be able to talk on the phone. Maybe, probably not. They'll hear sounds. They might kind of, with lip reading, be able to kind of follow conversations. If I get that same person at 9 or 10, the best they are going to be able to do is be able to have it as a safety mechanism, to know if a truck is coming up behind them or if the fire alarm is going off in their house, which again, still is a useful thing to have, but if I had gotten that same patient when they were very young, I could have actually given them the ability to speak on a phone and interact with the world normally. So this is this and sudden sensorineural hearing loss are the 2 things I'll preach about all day. But if you have a child who fails a newborn hearing test, make sure they get appropriate follow-up, and make sure they get appropriate follow-up within the first 6 to 9 months of life, not 2 to 3 years down the line. The reason for that is that children, when you're born, you don't really have all the hearing pathways set up yet. You develop those over your first couple of years of life. That's how you learn how to talk and interact. If you are deaf, you will not develop those neural pathways. So getting someone when they're still in kind of that neuroplastic time period is really important. That leads into postlingually deafened people, which is the vast majority of our practice, which is patients who were born normally and either from old age or from other issues have lost their hearing. Those people generally do very, very well because when they were a child, they were born normally. They developed all the normal neural pathways. So as long as you don't let them go 4 or 5 years with deafness, they will do very well. From the moment you turn them on, these people will actually start to get a lot of benefit. I've had patients say, hey, look, it's the first time I've been in church in 6 years and I could actually hear what the pastor was saying, and this is a week or 2 after they've been implanted. They're going to continue to get better over 6 months, but adults start off much better than kids. Kids need a lot of time to be trained in it, but postlingually deafened adults do really well. So Just to give you a little bit of an idea, we don't activate them right away. Patients are always very sad when I tell them that when they wake up from surgery, they're not going to be able to hear yet. We give it about 4 weeks to heal, and then our audiologist will actually activate the device. It also requires, particularly in children, a lot of programming sessions. So it's not just kind of a one surgery and done. Really kind of the heroes of cochlear implants are not actually the surgeons. You know, people are like, oh, it's so great you do cochlear implants. Like, it's a surgery, it's a great surgery, I love doing it. But the people who really kind of make the magic happen are our audiologists, who are able to work with the patient and kind of finally program each individual implant to that patient so they get the best benefit. So it's not just a one-time thing. It really requires a lot of effort on the patient's part afterwards to kind of be involved in both rehabilitation and programming. But like I said, if you have a high-performing cochlear implant user, that's a person who's going to be able to speak on the phone, they're going to be able to go to normal class, they're going to basically be indistinguishable from the rest of the world outside of the fact that you see a little speech processor on the outside of their head, which we are working on making it fully implantable. We're not there yet, but we are trying very hard. So how a cochlear implant works, very briefly. So cochlear implant has two parts, an external part and an internal part. The external part is what we are trying to make internal. We're just not there yet. It's very hard to make a microphone that you put inside somebody that hears as well as an external microphone. But the internal device actually has a magnet in it, and people always ask, well, how long am I going to have to wait till I change the batteries out? And actually, it's a very ingenious design. The way the magnets are set up is they actually function as induction coils, so the external processor actually charges the internal processor. So if you get an implant put in, you never need to charge it, you never need to take it out, you never need to change it. Really, the only time you get it kind of upgraded or changed is 20, 30 years down the line, and you need, there's just newer processors that are out. It's kind of like your Mac finally stops updating your iOS. It's kind of at that point in time. And we're actually getting now where I see a decent bit of patients who were implanted, in the early 90s, and they've just finally gotten to the point that they just need new internal processors, but their implants function fine. They're only getting it because they want to like link to their iPhone or something of that nature. But you think I'm kidding? That's really like the biggest reason they want to. Moving forward, there are 3 companies that are FDA approved in the United States to do cochlear implants. The Cochlear Corporation, Advanced Myonics, and Med-El. We implant all 3 at Hopkins. Most centers implant all 3. We try to not be part of the company competition there. And each one kind of has their own like individual benefits and downsides. So a little bit about the surgical technique. I think a lot of people are very worried that it's a big surgery, that there's a lot of risk involved. And for a patient with normal anatomy, it is probably one of the easier, straightforward surgeries that I do. It's one of my favorite surgeries to do because it's normal anatomy. Most of the time I'm dealing with abnormal anatomy. So a normal cochlear implant is like a pleasure of a day for me. But it's a very small incision, you can see, really just kind of right behind the ear. We make an incision behind it. We actually have to slide the magnet and the internal processor actually up underneath the skin here, and that's actually how the external processor clicks. So there's a magnet under the skin, and then the external magnet will come and click on the outside. And then we perform what's called a mastoidectomy, basically just the bone that's behind your ear. We open up. It's kind of like, think of it as like honeycomb-shaped bone. It's nothing that you need. It's nothing that you will miss. Evolutionarily, we're not even sure why we have it. Dolphins use it for echolocation. We're not quite sure why we have it, but it's nothing that patients miss. So we open that up with some high-speed drills, and then one of the reasons that you kind of send a person for this surgery to someone like myself who's spent a lot of time, and this is all we do, is that the area that we actually get to implant is right here. So this kind of area is the facial recess. So the facial nerve, which is the nerve that controls all of your peripheral facial function, runs about here. And the chorda tympani nerve, which is the nerve that gives you taste to the anterior 2/3 of your tongue, runs about there. And there's usually, depends on the patient, but about 2 to 4 millimeter opening right there. And so we open that up and go between those areas. So when I tell people 2 to 4 millimeter opening, they think that I'm nuts, and that sounds like a terrible, dangerous surgery to do. Under a microscope, it looks much bigger, I promise. But with normal anatomy, it's a very safe surgery. Injuries to the facial nerve happen, way less than 1% in experienced hands. And in my mind, that should be a never event for a normal anatomy cochlear implant. So let's see if this works, maybe. Yeah, there you go. So you can see we use high-speed drills to open it up. And right behind this area, the facial recess, you'll see is actually the cochlea and the round window. So the round window is the end of the cochlea that I was talking about, where the end of the fluid actually bounces off at the end. And we use that as a minimally invasive way to get into the cochlea. So this is, sorry, I flipped you guys. This is other side ear. So this is the nose is up here, top of the head's up here, feet are down here, and back of the head's here. So this is your second bone of hearing, the incus. This is your second bone of hearing again, and then this is your third bone of hearing. And so if you actually touch this in the OR, you'll see this move, which is always cool, and I love showing students. Everybody gets excited about it. Even cooler though, if you touch this, you'll see this move. You'll actually see this little membrane, which is the round window. You'll actually see it move because fluid is literally being moved through it as you do it. So it's always nice to see anatomy actually work like it is in the textbooks. So what we do is we open the facial recess, and then we will make a small opening into the round window, which you'll see here. And then that's how we actually insert the electrode. Thank you, Will. Hopefully I cut this video down to short enough. There we go. So we use a small drill to open it up. And one of the things we used to do is we used to just kind of plow through this with a drill, for lack of a better term, because the electrodes used to be so big that we had to, which is why it used to be that any residual hearing you had automatically was lost with a cochlear implant. Now they're so small that I can actually implant them through this small round window without actually having to break any other area of the cochlea. So oftentimes we're actually able to have people keep their residual hearing, or at least part of it, if not all of it. And there's just a little bit higher resolution view of the round window. So there are lots of different technical tips and things like that, but basically each company has kind of a different way that you insert, but the idea is to do it as atraumatically as possible. And so this is just a picture of one of the company's electrodes being inserted. So this is what we call an advanced soft stylet. So the electrode is pre-curved, so it'll curve around the cochlea, and there's a small pin that's keeping it straight. So when we pull the pin out, it will naturally curve around. And this is just another one of the companies being inserted. And then afterwards, I'll get an x-ray afterwards to make sure that it looks like it's in the right spot and that it hasn't folded over on itself. Because as you can imagine, we're putting it in here, this is all we can see. It's actually very hard to figure out how it's going on past that. And one of the reasons we think sometimes people do poorly with cochlear implants is that either the tip of the electrode is folded over or it hasn't gotten in the right spot. And so that's kind of the cutting edge of what we're trying to get better at now. So I mentioned this earlier, but as of, I believe it was July of 2019 or June of 2019, the FDA has also approved cochlear implants for people who have single-sided deafness. So if you have someone who has hearing loss in an ear for one reason, or they had sudden sensorineural hearing loss that I was talking about, those patients used to not be able to be approved by insurance companies for cochlear implants. We knew it helped, but like most things in America, we had to make sure it got paid for. And so companies were really hesitant to approve that because the devices are expensive. Finally, one of the companies was able to get enough data to the FDA that is now FDA approved. So it is something that we can perform now for people who have just single-sided hearing loss. So just a little bit to give you kind of an idea of kind of the cutting edge of the future. I spend most of my academic time when I'm not operating in the robotics lab up at the Johns Hopkins campus, so the LCSR, the Laboratory for Computational Sensing and Robotics. And what we're working on there, and we actually collaborate with a few groups at Vanderbilt and other places, is trying to find ways to actually make our insertions better. So if you can see from those videos, we're kind of inserting it and we can see it going in, but once it goes past that round window, I have no idea where it is. I think I know where it is, and you know, we're surgeons, so we're sometimes egotistical, so we always say, oh yeah, I know it's always in the right spot. In reality, we don't. And we think that a lot of times that might actually be a reason why we're not getting as good of outcomes as we want in some patients. So we're trying to use computers and robotics to help that. So this is actually from Rob Lavity, who's at Vanderbilt, who has been working on ways to actually get intraoperative, not just x-rays, but CT scans, and use some deep learning algorithms to predict exactly where that is in terms of the 3 chambers of the cochlea. We want it to just stay in one chamber. Sometimes it actually goes to the wrong chamber. And one of the other things that they're looking at is when we talked about it being tonotopically mapped, most electrodes have anywhere from 22 to 28 electrodes in them. And so those are kind of wrapped in a circle around the cochlea. We can set each of those electrodes to send out a certain signal. Sometimes those electrodes are actually too close to each other where they actually cause some kind of disruption in the signal. Basically, you're getting too much information. And so we're trying to use things like this to actually help our mapping system to be able to give us better outcomes. One of the other things we're trying to work on is using augmented reality. So we do this up in our lab and trying to find ways to actually give us better views in the operating room to have a sense of what the orientation of it is. So this is just a quick augmented reality clip of the temporal bone. So you'll see we're scanning just a little bit through this, and then right about there, very small, but you'll actually see the cochlea. So we're trying to get it where in the OR we can actually basically be able to see through bone, so we can get a better sense of how we're inserting. And then one of the final things that we're trying to do is actually be able to kind of make surgery easier. So if you have, if you've bought a new car in the last 5 to 10 years, you've probably noticed that they now have all these safe features where, you can try to get in a wreck and it'll keep you from doing that. Everybody loves that. Everybody loves that. Everybody freaks out about fully autonomous driving though. Long conversation we can have about that. But so we actually think that semi-autonomous surgery is a much more viable way to the future. We think it's something the public will tolerate much better, and we actually think it's something that can help. So we're trying to build kind of the equivalent of a Lexus navigation system for surgery. So what we're doing is we're basically taking all of those things, the brain, the sigmoid sinus, all those things that I said that you can hit earlier that are bad when we're doing these cases. We're trying to make it where you physically cannot hit those. It's, I kind of give it the analogy, if you've ever gone bowling as a kid and you put the bumpers up on the side, if you try to throw it in the gutter, it won't let you. We're trying to kind of do that for ear surgery. So basically we will take a CT scan, augment out exactly where we want the drill to be able to go and where we don't want the drill to be able to go. And then we can actually use, this is one of the cooperative control robotic devices we built up there. And you can see you can actually go in and just clip a drill in, and then the robots, or the surgeon still moves the drill like they normally would, but the robot is able to keep track on where the tip is. So if you happen to try to bang into the brain, bang into the facial nerve, bang into any of those things you don't want to hit, it will actually stop you. So kind of you're, again, bowling with bumpers. So this is actually a video of one of my grad students who is definitely not a surgeon, but set it up where, hey, you can only drill where it tells you to. And you can see he's trying to hit where the brain would be and it won't let him go. He's going to next try to hit where the ear canal would be and it won't let him go. Also, all surgeons probably have high frequency hearing loss because of listening to this all day. But so those are some of the things that are kind of on the cutting edge. The other side of this is non-surgical ways to improve hearing, so what we call hair cell regeneration. And that is also a very hot topic right now. There's a ton of venture funding being thrown into a lot of different companies, and a lot of different groups are working on that, actually both at Maryland and at Johns Hopkins. So hopefully in 15, 20 years, I'll be put out of business when it comes to cochlear implants, and I'll have a drug that I can just inject that will fix your hearing loss. We're not there yet, and I think I bring that up because a lot of patients will ask me, they're like, well, I don't want to get a cochlear implant when something else is coming down the line. It's coming down the line. It's not coming quickly down the line. There have been a few clinical trials. None have been good enough to kind of move on to the next stage, but it is something that I do think will be in the future, but it's just, we're not quite there yet, but hopefully soon. So at the very end, I just put, this is the phone number. If you have a patient who you think needs to be evaluated for a cochlear implant, or you think has sudden sensorineural hearing loss, that's our main clinic line. Please feel free to call that. If you tell the patient, all they have to say is, I had a sudden hearing loss, and my doctor thinks it's nerve hearing, they will find a way, either me, one of my colleagues, I'll have one of my fellows, someone will see them within 3 or 4 days. We will make sure that they get in, because it is, like I said, it's one of the few true kind of otologic emergencies we have. I hate seeing patients. I saw one 2 days ago who had hearing loss a month and a half ago, and they're just getting to see me now because they were like, it's probably no big deal. If I could have gotten that person sooner, I probably would have had a better chance of getting their hearing back. So this is also just my email. If you have any patients who you need seeing, feel free to send up. We're happy to help triage. But I think we have about 5-10 minutes left. Any questions I can answer for you?
I have 2 questions.
Yeah.
One, most people with hearing aids and people with cochlear implants still have problems hearing in high noise situations like this. Could you say something about what's being done to correct that or to improve the implants? And the second question has to do with removing the cochlear implant electrode.
Yeah.
Can you say what the complications are?
Yeah, so the first question, so people who have hearing aids, they still usually, if you put them in a restaurant or somewhere that there's high background noise, they oftentimes have a hard time hearing. Patients who have cochlear implants also oftentimes still have that problem. They're much better now than they were 10 years ago, but they still have that problem. We call that kind of speech and noise testing. So For hearing aids, people are trying to do better jobs with bandpass filters on the hearing aids. I feel like in many ways they've kind of tapped that a little bit. What now is kind of becoming more in vogue is actually people, instead of just having the hearing aid, if they're at a conference or a meeting or something like that, they have the hearing aid, but they also have something, either their phone or another microphone that they can actually put in front of the person who they're listening to, so that they can actually use kind of a directional microphone, which has been fairly successful in the right settings, particularly if you're having a conversation with a single person. Doesn't work as well if you have 4 or 5 people talking at once. For cochlear implants, there's been a lot of, that is really kind of what we've been trying to make better for the last 10 years, and kind of the next foray is into actually getting people to truly appreciate music. That's kind of a higher complex sound, and I think they're very linked. Part of it is being able to be specific enough with the electrodes to be able to fine tune out noise. People are looking into different ways of stimulating the inner ear instead of using electrical current, because electrical current has a wide spread, and so it's hard to be very specific and precise with it. People are looking at using things like light activation, where they actually give a rhodopsin molecule to a rodent, which makes its cochlea actually react to light. So you will fire an electrical signal if you turn a light on. So instead of having electrodes, we'd have basically like little, basically LED lights. Very early stage. Most of what's being done right now that's kind of real world applicable is actually making better programming. So saying, hey, look, I have all these electrodes. Is there a way that I can program them better so there's less overlap and less interference? But it's definitely still an issue that patients have, and probably in some ways it's a good problem to have, because patients, they're like, oh yeah, when I have a really hard time is like when I'm like out at a concert or something like that. It's like, well, yeah, that's great because you're still able to talk on a phone and you're so much better than what our best would have been 10 to 15 years ago. But now that's kind of our final frontier. So we don't have a great solution for it, but there are a lot of people trying to work on that right now. One of the things we tried and we thought was, hey, look, if we put 24 electrodes in, why not just put 40 or 50 electrodes in somebody? And that will be better because we'll have more electrodes to stimulate. But the electrical current spread of each electrode is what's kind of limiting us to do that. So I think we've kind of hit the maximum number of electrodes we can have. We've got to find new kind of innovative ways to do that. So.
And removing a...
Oh yeah, sorry. So removing, so it's rare that I have a patient who wants to have a cochlear implant removed. I feel like most of the time those are patients who got implanted, they were either born significantly deaf or significantly hard of hearing or deaf, and they got implanted later in life. So they're getting kind of noise awareness out of it, but they're not necessarily getting kind of speech understanding. And for those patients, if I think they're getting benefit, I generally try to advise people to try to keep it, because they never know if in 4 or 5 years they might want to use it more. But I do have patients who are just like, look, I've thought about it, I'm 100% sure I want this out. Taking it out is really not that big of a deal. Taking it out is probably about an hour-long surgery. If that, you're able to remove the magnet. You're also able to go in and take the electrode out of the cochlea. Really the only main risk to it is that they have any residual hearing left. There's a very high chance that removing that electrode will actually cause them to lose that residual hearing. But it's not something that I think of as a risky surgery to do. Most of the time we're going in to remove implants, though, it's actually to remove an implant and put a newer model in, is most of the time. So, but I feel like I've had a lot of patients ask me about that. They're really, and I'm not really sure where it comes from, but I think in the past was a lot of hesitancy to remove cochlear implants, and so a lot of patients were like, oh, I got this thing and I hate it and I don't want to have it anymore, and the surgeon won't take it out for me. I think now if someone's not getting benefit from it, I don't see a reason to keep it in for them. Any other questions at all? All right, well, thank you guys so much for having me. Oh, sorry? Yeah.
So what's the hearing loss that might give you radiation?
Yeah, so that's a really good question. So most of the time it does not, as long as the problem is in the ear or the cochlea. Patients who have strokes and have a central problem, which is causing it, so their cochlea is working fine, but their problem is that the actual cochlear nucleus inside the brain is damaged. Those people are not going to do very well with cochlear implants. So oftentimes patients who have neurofibromatosis type 2, which is a rare disease, but these people will get bilateral acoustic neuromas, and unfortunately that naturally is going to make them lose hearing on both sides, but it's making them lose hearing on the actual nerve, not in the cochlea. They do very poorly with cochlear implants. So auditory brainstem implants, where we actually implant an electrode directly onto the area of the brain that is in charge of hearing, we do, and the results are okay. They're not great. There are some centers that get better results than others, and there are some very high volume centers that do it, particularly in Italy. But it's not nearly as good as a cochlear implant. So patients who have it from meningitis, that's usually fine, because usually meningitis is ossification of the cochlea afterwards, so that's usually not an issue. Patients who have stroke or brain radiation as an issue, though, oftentimes that can be an issue. There are specific tests we can run on those patients, though, to find out where along the chain of hearing is the problem. So a thing called an ABR, an auditory brain stem reflex, we can do, and that'll tell us, hey, look, is the problem in the cochlea, or is the problem a lot further up the chain? So that's a great question. All right, any other questions? All right. Yep.
Yes, are Cochlear Implants MRI compatible?
Another great question. So they used to not be. And that used to be a huge problem. So patients who had reasons they needed to get MRIs would have to oftentimes get their the magnet taken out and then put back in, which is just a huge pain for everybody. More recently, I believe all three companies now, I know at least two of them, I think all three have it out or about to, actually have MRI compatible cochlear implants. So they're MRI compatible up to 1.5 Tesla. If you need something higher, you can do some cochlear implant wrapping that's not FDA approved, but we will do it at Hopkins for you if you need it. If you have a patient who has a cochlear implant, and they need to get an imaging, and the group, local group won't do it, you can send them up, and it's a process, but we can get them set up for an MRI, even if they have an older version. Now with the newer versions, though, you can get it up to 1.5. It's actually kind of genius. They switched the polarity of the magnet, so if you are in an MRI, instead of the magnet being pulled out, it just spins. And when it spins, it might cause a little bit of heat, but it's not actually going to cause any damage. So patients do very well with that now. So the newer models are definitely MRI compatible. And I've had a few, not many, but a few patients who actually the reason they want me to upgrade their device is they want to be MRI compatible. So. All right. Any other questions? All right. Well, thank you guys so much. If any questions, feel free to email me. And thank you for the attention. Appreciate it.